Hello. Let's continue now talking about our patient with chest pain. Remember that we had a 50-year-old gentleman who had 1 hour of chest discomfort or tightness. He had a slightly low blood pressure and some sweatiness on physical exam. We know that when we see any chest pain patient, we need to be concerned about ischemic heart disease, the #1 killer worldwide in both developed and developing nations. Ischemic heart disease, when we see a patient with chest pain, we think about acute coronary syndrome, which we divide into 2 categories: acute myocardial infarction or heart attack and unstable angina. Acute myocardial infarction is frequently divided into ST elevation myocardial infarctions and non-ST elevation myocardial infarctions because these patients are treated differently. Unstable angina is really ischemia without infarction, or new or changing ischemia without infarction. So no cell death, but yet the cells are not getting enough blood flow. There are 5 classic coronary artery disease risk factors that were identified in the initial study. These are tobacco smoking, high blood pressure, elevated cholesterol, diabetes, and a first-generation family member who had early coronary artery disease, men less than 55 or women less than 65 years of age. Other coronary artery disease risk factors, though, have been identified, such as lupus, obesity, older age, receiving hormone therapy such as estrogen, lack of exercise, and elevated homocysteine levels. Our patient had no known coronary risk factors or history of coronary artery disease. So the question we have to ask ourselves is, does this patient have acute coronary syndrome as the cause of his chest discomfort? You have to be careful with using risk factors to exclude ACS. Risk factors are a poor predictor in an individual patient of whether their symptoms in the emergency department are due to ACS. Risk factors are good at predicting your long-term risk of developing ischemic heart disease, but not good at predicting the risk in a patient who's sitting in front of you in the emergency department. Also, do not exclude ACS because of non-classical or atypical symptoms. We know that classically, these patients present with chest pressure or tightness that radiates to the arm or jaw on the left side, but atypical symptoms are common and they happen frequently. In fact, in patients with ACS, or acute myocardial infarctions in this case, 22% will have sharp or stabbing pain versus the more traditional chest pressure. 13% will have pleuritic pain, pain that is worse when you take a deep breath. 7% will have pain that's worse when they move or when you push on their chest. And as patients get older, a higher and higher percentage have no pain when they have a heart attack. And in patients that are diabetic, female, or of older age, a high percentage, more than 20%, will have no chest pain when they're having an acute myocardial infarction. One thing on history that is helpful in determining if the patient's chest discomfort is due to ACS is figuring out the length of time that the symptoms have been going on constantly. In patients who've had a very short length of time, so their chest discomfort or pain was less than 1 minute, it's very unlikely to be ACS. In patients who've had chest discomfort or pain anywhere from 5 minutes to 60 minutes, they have a much higher risk of it being ACS as the cause. And this is also true for our patients who've had pain for less than 24 hours constantly. If the patient has constant pain for greater than 1 day or greater than 24 hours, it's very unlikely to be ACS as the cause. When we see our patients, we want to divide them into 3 categories: likely or definite ACS, possible ACS, and not ACS. So the patients that fit into the likely ACS category are patients with clear ischemia on ECG, so ST elevation or ST depression that is consistent with ischemia. Patients with positive cardiac markers, or patients who had a very high risk based on their history and physical exam. So in a patient with a history of coronary artery disease requiring a bypass graft or CABG, who comes in with their symptoms that are the same as the last time I had a heart attack, those patients are very high risk just based on that, and I would place them into the likely ACS category. The not ACS category is patients who have a clear alternative diagnosis and a low baseline risk. So if the patient comes in, they have a cough and a fever, they're 20 years old, and your chest x-ray shows an infiltrate, these patients can be placed into the not ACS category and not have a further workup for acute coronary syndrome. A large percentage of our patients, though, up to 50% of our patients, end up in the possible ACS category, where there's no obvious ACS, but no clear alternative diagnosis or cause of the patient's symptoms either. And so then we have to say, what do we do with this group of patients? So in our patient, we get his initial ECG, and when you look at the ECG, you can see that it's a normal sinus rhythm. The QRS is narrow. There are no Q waves and no ST segment changes or T wave inversions suggestive of ischemia or infarction. So this is a normal or near normal ECG. We then have to say, well, should we send cardiac markers? And the answer in this patient is a definite yes. We had put him into the possible ACS category, and so we want to get cardiac markers. Now, what cardiac marker is available to you is going to be dependent on where you practice or work. In the United States and in many other countries, they're using troponin or recommending troponin as the cardiac marker of choice. And when using a troponin, other cardiac markers such as myoglobin or CKMB are not necessary. In other places, troponin may not be available to you, and CKMB is another marker, although less specific than troponin, of an acute myocardial infarction. What you want to look at carefully, though, is the time it takes for that test to be positive. Because when the cells die, they have to release these proteins into the bloodstream, and then we have to have them in a high enough concentration in the bloodstream for them to be called abnormal. So when you get that initial cardiac marker in a patient, such as our patient, who's only been having symptoms for 1 hour, you would expect the troponin, even the CKMB, to probably be normal. So although you do want to get that initial test, because if it's positive, we want to act on that and treat the patient differently, we also need to get another cardiac marker or a follow-up marker at an appropriate time interval. Now, some places are advocating the use of rapid ones with testing every 1 to 2 hours of the cardiac markers. But if they're negative, you at least want to get one test that's at an appropriate interval, such as 6 to 8 hours from the onset of patient's symptoms, depending on which cardiac marker you're using. Be careful excluding acute myocardial infarction after a single negative cardiac marker. This can be done, but only if the patient has had constant symptoms that you can map out very clearly when the symptoms started and that they have not come and gone. Should we have a concern for ACS in this patient? We have a 50-year-old man with chest discomfort and 1 hour of tightness, no cardiac risk factors, an unremarkable ECG, and an initial cardiac marker which was negative or normal. I would say, given this patient's concerning history, we would still put them in the possible ACS category. So in summary, we want to classify our patients with chest pain as having likely ACS, possible ACS, or no ACS. And we want to remember some key things: that patients with ACS may have no risk factors, atypical symptoms, unremarkable or near normal ECGs, and negative initial cardiac markers.